So yeah, as Nicole said, my name is Laura, and I am one of the bone marrow transplant coordinators from the Royal Brisbane Hospital. So some of you may have seen my name, may know me, or maybe going to get to know me soon, but otherwise in your home hospital, wherever you're having your treatment, you would have an equivalent version of me that you'll be working with throughout the process of undergoing your treatment for and/or transplant. Just before I get started, I'll introduce a couple of my colleagues. So in the back we have David Williams, and so he is the nurse unit manager of the transplant ward at the Royal Brisbane Hospital. So he's kindly come over today, so if anyone has any very specific sort of ward questions, David will be able to help us out. Lots of knowledge and expertise there. And Caroline Stewart, she is works in our transplant coordination unit as well, and she's what I call one of the data gurus, keeping lots of information up on all our transplant numbers and all things around you know, where bone marrow transplants been and moving to in the future. So today, yes, the talk is about autologous bone marrow transplants. I'm going to go over a few things that we're going to cover, but I'm really keen for you to stop and ask questions whenever you have them. If you don't understand something that I'm talking about at the time, just pop your hand up, we'll have a chat, and then otherwise at the end we can go over anything that anyone's still a little bit unsure of. So before we start, just with a show of hands, I don't know many of the faces here, so I know that you've come from all different hospitals. We do autologous transplants at a number of centres in Brisbane and in Queensland, but predominantly are people sort of on the path to heading towards a transplant? Is it in? A lot of people know the timeline that they're on, or it's just still a learning process. Is anyone in the process of getting ready for their transplant at the moment? Okay. Beautiful. So beautiful. So some of this stuff may be familiar to you. Some of it might be a little bit specific to the Royal Brisbane Hospital, like some of the housekeeping sides of things. But overall, the processes will be the same at all the hospitals, and the idea behind what the transplant is there to do will be the same. And if I can't answer the question specifically to your environment, one of us may be able to. If not, we can certainly find out for you. So this today is what I want to go through with you all. So I just want to set the scene a little bit about the difference between an autologous and an allogeneic bone marrow transplant. That's usually where I start my education with all of the patients that I see. They are while they are both major sort of medical procedures and both under the bone marrow transplant banner, they are very different. And the process of undergoing those transplants is very different, and the post-transplant side of things is quite different also. Then we'll go into a little bit of detail about the autologous stem cell collection. So that's actually collecting the stem cells from you and getting them into the freezer. So that's step number one of an autologous bone marrow transplant, and it's very important that we separate those two processes out, because process number two can't happen without the success of process number one. We'll talk about the assessments that routinely patients would undergo before having a bone marrow transplant with us, and very similar in other hospitals. We'll talk about the conditioning chemotherapy, and there's a few different types of regimes used before people have their transplant. We'll look at what actually happens on the transplant day, so how it all happens while you're in the bed. We'll talk a little bit about the role of carers there and some important tips and tricks for that day. Some of the side effects that we will expect to face during the transplant. Engraftment, which is what we call sort of the process that happens when the stem cells have found their home. And discharge, so going home, and a whole lot of practical things around that, which I find mostly is what people are very interested to know. This is obviously quite a major change in in families and lifestyles, etc. A lot of people have relocated for transplants and things like that. So understanding the practicals of making it as smooth as possible is also what we spend a lot of time doing with people. So just a few facts about autologous bone marrow transplants before we get started. So in 2013, over 1,000 transplants were performed in Australia across 40 different centres. And in the last 2 years at the Royal Brisbane Hospital, we've done 102 autologous bone marrow transplants. So there's a lot. We do them frequently. We do a lot more of the allogeneic bone marrow transplants as well. And we are one of a few centres at the Royal Brisbane Hospital that can do those. However, the autologous transplants are sort of more frequently performed throughout centres in Queensland, as many of you will know. Okay, so just briefly, I don't want to go into too much detail about allogeneic bone marrow transplants, but the important thing, let me see if I can get this light. So you can see here is the autologous transplant column I've got and the allogeneic transplant column here. So with an autologous transplant, we're aiming to treat lymphomas and multiple myeloma. Okay, so most of you sitting here today probably will have one of those diagnoses will be familiar to you in some form. So to do the transplant for an autologous, someone having an autologous transplant, we need to have the stem cells, okay, from the person. So auto meaning self, you are the donor for yourself. So throughout the process you'll hear the word donor a lot. Now in the setting of having a donor from a brother or a sister or someone else in the world, that is obviously the donor. But in terms of an autologous bone marrow transplant, you are the donor for yourself. So a lot of the workup side of things talks about donation, donor health questionnaires, donor assessments, etc., etc. You are being assessed as a donor for yourself. So that can be quite confusing for people sometimes. But basically that's the source of where the stem cells are coming from, and that for you guys in this case is from yourselves. We'll talk about the length of stay in hospital, which is always a hot topic, but you know, one that unfortunately we can't answer because there's so many unpredictable variables, but we can tell you roughly how long people would be scheduled to be in hospital. Length of stay in Brisbane, for those who aren't from Brisbane, the risk of rejection, so when it's your own cells, we're not looking at going down a path of navigating what's called graft versus host disease, which is a major complication of an allogeneic bone marrow transplant. But you cannot get graft versus host disease when you have an autologous bone marrow transplant. So I would say that's probably the number one question I get asked in education around autologous bone marrow transplants is, what if I reject this and what if I get graft versus host disease? Well, you can't. So that's really important to remember. So when you're in waiting rooms, when you're reading on Google, hopefully not, when you're reading on the Leukaemia Foundation websites, etc., and bone marrow transplantation is coupled with graft versus host disease, some of the facts around that can be really scary, but it's really important to remember the type of transplant that you're having, and when that is an autologous bone marrow transplant, graft versus host disease is not a risk. Okay? And CVAD, so that stands for Central Venous Access Device, and that's the device that we will put in to do the transplant, to use as your venous access, to use to get into your bloodstream. So same type of idea as having a cannula in your arm or a PICC, but what we actually use is something called a Hickman line, and it's, yes, going into your bloodstream, the same concept of putting IV fluids into a vein in your arm, but it allows a lot more to go in a lot faster, allows a lot more to come out a lot faster. It can stay in for a long time, and it doesn't deteriorate over sort of 3 or 4 days as a cannula in your arm would. Okay. Yes, there are some risks around it with infection and things, but we'll talk about those as we go. So yeah, that's the difference, to set the scene. And a really, really important one for you all to remember going into your transplant is that we just need to have our eyes open to things that are relevant to autologous bone marrow transplants. We would sometimes move people to an allogeneic transplant with lymphomas and myelomas, but usually they will have undergone an autologous bone marrow transplant first, or have some quite specific disease-related, circumstances that would need to move into an allogeneic transplant space. So yes, we can definitely move into an allogeneic transplant space for lymphomas and myelomas, but most of the time those people will have undergone an autologous bone marrow transplant beforehand. However, with people with leukaemia, so acute leukemias for example, the option of having a autologous transplant first is not an option, okay? So they move immediately to an allogeneic transplant, as opposed to sometimes the other way around with lymphomas and myelomas. Okay, so we've got the treatment path that we might be heading towards an autologous bone marrow transplant. So we've had a diagnosis, we've had some treatment, whatever that may look like for the individual depending on the disease. And now the doctor starts to talk about wanting to maybe do an autologous bone marrow transplant with you. Now some hospitals and some doctors may also use the word stem cell rescue or a stem cell transplant, and essentially they mean the same thing. The word bone marrow is quite a historic word and comes from a long time ago when we didn't have the ability to collect stem cells the way that we do now. We needed to collect bone marrow like you would when you have a bone marrow aspirate. So we would take quite a while ago, we would take patients to theatre and do a sort of extended bone marrow aspirate to remove the bone marrow to then use for the transplant. But in sort of this day and age and onwards, we're very much moved into a stem cell collection phase. So that's where that word comes from. But they're used interchangeably and they essentially mean the same thing, okay? Without having some stem cells in the freezer with your name on them, we absolutely cannot have an autologous bone marrow transplant. So step number one is to collect the stem cells from the patient, okay? Now that's done, that can be done under a few different ways, usually using chemotherapy, so a high dose of chemotherapy to wipe out any residual disease that may be there. And then we use what's called GCSF injections, so a lot of you probably are familiar with those, and that stands for granulocyte colony stimulating factor, which is basically a big word that it means it produces lots and lots and lots of stem cells in your bone marrow, okay? So I describe that to people as at the moment in the bone marrow, there's, in my bone marrow for example, there is lots of stem cells floating along nicely in that space, and it has quite a lot of room. But if I was to give myself these injections overnight for the next however many days, the number of stem cells in there would be multiplying very, very quickly, to the point that there's so many in there that the capacity the bone marrow can't take any more, and it spills them out into the bloodstream. Okay, so it's getting very, very full, which is why it often causes your bones to ache, which I'll talk about, and it's getting so crowded that it has to go somewhere, and it comes into the bloodstream, and then we can collect the stem cells from the bloodstream, which we'll talk about. So it can be with chemotherapy first, and then the injections, and then the collection procedure, or we can just, in some people's cases, we can just use the injections. They don't need to have any chemotherapy depending on where their disease is at that particular time. And sometimes we use another drug called Mosabil, which is an extension of GCSF, and it really, really ramps up that process of moving the stem cell, producing the stem cells and moving them from the bone marrow into the bloodstream. Process of having those injections and the chemotherapy is not usually done as an outpatient for a lot of people, most people, and it's done in a way that tries to keep, daily life ticking along as much as possible, keeping the side effects to a minimum, and only admitting people into hospital really during that phase. At our hospital anyway, at other hospitals it's different, depending on, you know, if you're well enough to stay out, you'll be able to have it done as an outpatient. And so then the stem cells go to the freezer. So step before that is to actually collect them from the person. So we've got them all floating around in the bloodstream, we're ready to go. Our scientists do a special test on your blood, and we need the markers, that's the stem cell markers, which is all very scientific, but the stem cell markers in your bloodstream need to be at a certain level, and that indicates to us that there's enough stem cells there that we can collect them off and get them in the freezer for if and when you need a transplant in the future. So at that point, it's sitting in a chair or a bed in the day unit of your relevant hospital with your arms out like this. If you have reasonable veins in your arms, some people need to have a line put into their neck because the veins in their arms aren't particularly good. But at that point, you sit and chat, watch TV, talk for about 4 to 6 hours while your blood goes through a washing machine, I like to call it. So it comes out one arm and spun very quickly in a machine. It's called an aphoresis procedure. And when we spin blood very quickly, it separates into its different layers, okay? So imagine oil and water going into a cup. They're going to naturally separate out. So the blood would separate into its 5 layers, and one of those layers is the stem cells that we want. So we program the machine to collect just that layer of the blood, and it accumulates up here in a bag, which looks exactly like a bag of blood or a bag of platelets if you've seen what that looks like. And it collects what it wants, and it pumps everything else back into your other arm. So you sit there while that process is taking place, and your blood volume usually goes through the machine 3 times. And that's then how enough stem cells are collected, and depending on the disease we're treating would depend on how many stem cells we need to get. So some myelomas will lend themselves to needing to have sometimes more often 2 days on the machine because we're looking for a higher dose at the end to have in the freezer. So it's all based on how much we want to get in the freezer at the end of the day for your type of transplant and your type of disease, and it's worked back from there as to how long the procedure will go for. But that's the first step we want to get through, because there's no talk of an autologous bone marrow transplant if we can't get that process happening for people, okay? So then they're put in the freezer with the scientists and very carefully stored for a number of years. So we've used stem cells that are 10 years old, 12, 15 I think is probably one of the oldest I've ever seen. But routinely people will use them within the few months after they've been collected. So any questions on how we collect the stem cells? You might think of some. Okay, so now we want to talk about what happens before we come into hospital, before we come in for the transplant. So we need to ensure that patients are medically fit prior to coming into a transplant, okay? So a lot of the general population would probably think that that you have a transplant at your worst time, particularly. You know, that would make sense as a treatment path, that you would be particularly unwell at that time. Ideally, we need to make sure that each patient is well enough to actually cope with the transplant, okay? Because it is a big dose of chemotherapy, multiple doses for some regimes, and we really want to make sure that people's hearts and lungs and their organ function, etc., is going to cope with that treatment before we bring them into hospital. What we don't want going wrong is a whole lot of cardiac issues, lung issues, breathing issues, etc., prior or outside of the actual disease that we're already trying to transplant. So it's a safety precaution that we undergo this prior to bringing you in for your transplant, okay? So it's done within 30 days of your scheduled bone marrow transplant. And for those having a transplant at the Royal Brisbane Hospital, it needs to be done with us. It would be very similar for those of you who are having transplants at other hospitals. Some of you will have had your treatment in other hospitals and maybe come to us for the transplant. If anyone's from Sunshine Coast, that's a very common practice for us, is having your treatment at the Sunshine Coast University Hospital but coming to us for your transplant. And that's simply because they don't do transplants yet. And it's usually over 2 days at the hospital, and it will consist of a whole lot of medical investigations. So we'll do a big education session with us, which is essentially what I'm doing here with you now, is a large scale one of these. We'll do a chest x-ray, an ECG, some heart scans, blood tests, breathing tests, and you might have a bone marrow aspirate if you haven't had one recently. So we want to check exactly where the disease, the staging of the disease, and then we want to check all of your organ function to make sure, as I said, that you're in the best possible condition to cope with what's about to come in the transplant. Okay? You'll see the social worker, a pharmacist, the doctor, and I have a tour of the ward. Okay, and they're all very standard for everybody coming and must be done. There is no negotiating any of these procedures. Quite often when you see the doctor, a whole lot of extra stuff is added on as a result of that. Again, all precautionary measures to make sure that we have been able to predict anything that may occur during your transplant and get onto it early. Okay, it also gives us a baseline of where everything's at. If somebody comes in and on day 3 of their chemo, their heart starts to go funny, or all of a sudden they're having breathing difficulties, etc., we've got a baseline to look back at before this started and see that, well, the function was normal here, 4 days later it's not, something's occurred during this process, or not, has this person always had this problem. Okay, so depending on the disease will depend on the type of chemotherapy people have pre their transplant. Now this is called your conditioning regime. So we want to condition your bone marrow for what is coming. Okay, so we want to make room essentially for the stem cells from the freezer. So we want to get rid of any last residual disease and then make the space for the stem cells to come through. Now, without having this is why it's often called a stem cell rescue, because to have these types of chemotherapy here, without some stem cells to come from the freezer after having that, the recovery time would be far too, patients just may not recover, would run into a whole lot of complications in the recovery. The doses of chemotherapy are very high without having the rescue of the stem cells to come and essentially rescue the bone marrow to get back in working order to produce some counts so that that people have white cells and neutrophils to fight infection, so that they have red blood cells, so that they have their hemoglobin is working to do all the things that it needs to do and produce your energy to function, etc., etc. We've got some platelets to clot the blood. If we just give these and we don't have the stem cells to come, the length of time to recover those yourself is detrimental to the whole process. So that's often why it's called a stem cell rescue, okay? Because the stem cells from the freezer are coming to rescue you post the chemotherapy. And they can vary in length from 2 to 10 days. So for example, a high dose melphalan autologous bone marrow transplant for multiple myeloma is a very common transplant that most hospitals will do. And for example, it only has a couple of days worth of the conditioning, okay? But for example, just go to this for a moment. This is the treatment sheet I've put up for someone having a beam auto. So the beam just stands for the 4 types of chemotherapy in the conditioning regime. And this is just a little snippet from what we would call one of our protocols. And you can see there that it actually goes over sort of 7 days. Before we're getting anywhere near the stem cell day, the transplant day, the patient has had a whole week worth of chemotherapy first. But back here in this high-dose melphalan, the patients only had 2 days worth of treatment prior. Okay, and some of these others, they're LACE and the MSK TLI, they're less common, but some of those even go up to 10 days. Okay, and you would well know if you were having anything sort of in the 10-day phase. Usually most of them are given as an inpatient, but as you can see, for some people they've sort of undergone a week to 10 days of chemo before they're even going anywhere near the stem cells from the freezer. So that would naturally tell us sometimes that the side effects coming with those will be longer lasting and not necessarily worse, but hanging around for a longer period of time before you get to the transplant. So just a bit of a definition there. The conditioning chemotherapy is used to destroy any leftover cancer cells, as I said, and to create space in the bone marrow for the new stem cells to grow. So that is what we are trying to achieve with an autologous bone marrow transplant, okay? So after we've had the conditioning chemotherapy, whatever that may look like for you, we're now at the day where we're going to have the actual cells, okay? So, I'll speak from how it happens at the Royal Brisbane, be very similar at other hospitals, but everybody is in their bed. There's also usually a lot of questions around, can you come out of the room, can you go, who can come into the room, all those sorts of things. I'll talk about them in a little bit more detail, a little bit down the track, but basically you're in your hospital bed at that point. Yes, you can get up, yes, you can move around if you feel like it, absolutely, there's no restrictions on that, but you will be in the hospital room, and there'll be a number of nursing staff with you, the doctor's usually quite close by, and the stem cells are brought to the bedside, so your frozen bag that was taken off a few months ago is brought to you at the bedside in what looks like a baby's bath. Okay, so a stainless steel bath, and it has it has got 37-degree warm water in it, which is our basal body temperature. So at the bedside, after a number of checks have been done to make sure it's the right bag, the scientists will spend a good sort of 15 or 20 minutes thawing out these stem cells standing next to you, okay? So we can't just sort of turn them from a solid frozen block like this to liquid within seconds. We need to gradually thaw it out to become back to the liquid form that it was when we collected them from the patient. Okay, now once it then goes up onto the line, it drips in like a bag of blood or a bag of platelets through that line I've talked about that goes into your neck, and anywhere from, look, we've got 1 to 2 hours. It sometimes doesn't take that long, depends how many bags there are, depends how you're tolerating it. There's a number of flushes of the bag that needs to happen to make sure every last little cell is washed out, but predominantly it's sort of a couple of hours, an hour to 2 process. Now when the stem cells have gone to the scientist originally to be frozen, they've mixed in a preservative agent called DMSO, and that's to preserve the stem cells' viability, so to preserve them so that they don't die while they're frozen, okay? Now unfortunately sometimes when you get those stem cells back, that preservative agent is obviously mixed in with the stem cells that have been frozen. So that goes into your body, and some people can have an allergic reaction to DMSO. We know that, so we avoid it happening, okay? And everyone is given pre-medications before the infusion of the stem cells go back in. So hydrocortisone, Phenergan and Panadol, as long as nobody's allergic to any of those, are given standardly to preempt an allergic reaction that may occur if we didn't give that. So they're basically antihistamines to prevent the allergic reaction from occurring. Unfortunately though, for any of you that have had Phenergan, you may know that it makes you quite sleepy. So quite often people will sleep through their transplant or be very dozy. Told you all that. You'll have multiple observations from the nursing staff, and stand over here so you guys can see. Multiple observations from the nursing staff throughout this process, and as I said, the doctor's there in the room. Very rarely would the doctor be needed, hopefully, but the nurses are highly trained in a very sort of specific process driven by a very specific protocol, and anything that varies from that will be actioned upon pretty quickly. But most people continue lying in their bed for an hour or two, quite dozy from the Finnegan, and this bag of stem cells slowly drips in. Okay? So at this point in time, we're dealing with the side effects from the chemotherapy, okay? So remember, this is the stem cells going in was the day after you usually the day after you finished your chemo or one day later. But the chemotherapy side effects don't necessarily take effect immediately. So what we're actually dealing with at that point is still, remember, just to scoot back to the start a little bit, usually when we come in, most of our blood counts are going to be up here at a reasonably sort of okay level. By giving this chemotherapy over that 2 to 10 days, depending on which regime you were having, we're really going to knock all those counts down low, okay, down to that phase where you're sort of running on not very much, which we'll talk about soon. And that's then going to take time to build back up once the new stem cells make their home. So in that going down phase, the chemo is really taking effect, and these are some of the side effects that everybody is going to get. What level of these you get, none of us know. Okay, so you may get a very, very small amount of all of these. You may get 2 of them terribly. You may get none of them terribly. You may get all of them terribly. And what we prepare people for is really the worst case scenario of all of them. And many, many people then fly by my office every day and say, I didn't get any of what you said. And that's a good thing. Okay, what we don't want is people coming past and thinking this is A, not normal, or nobody told me I was going to be feeling like this, because sometimes just knowing that it's normal to feel like you are is enough to be able to accept that, you know, it's going to be rough for a little while, and it's sort of all inside the box of what we would expect to happen. And I use this theory with my patients to say when things start stepping outside of the box of what we would see in the realms of sort of normal, essentially, that's when you know, we're stepping up our level of concern for a patient. But there can be a number of things that go wrong in terms of side effects and feeling terrible or feeling miserable that are actually quite normal side effects of chemotherapy or quite expected side effects of chemotherapy and a bone marrow transplant. Okay. So nausea and vomiting. Now most of you would have had some sort of chemotherapy up until now. I know a lot of you may have only had oral chemotherapy, but a lot of you would have also had IV chemotherapy. Certainly, if not for your disease, maybe in the mobilisation of your stem cells, you might have had a big dose of chemotherapy. So the same type of side effects are there. Usually they're just increased because of the larger doses of the chemotherapy that we're giving. Okay, so nausea and vomiting, we're very good at managing these in hospital, and usually everyone is on what we would call prophylactic medication to avoid and prohibit this as much as we possibly can, because once you feel sick, taking a tablet to help with your nausea, it's too late. We really want to keep the feeling sick away, because the feeling sick comes and then the lunch trolley comes and oh God, I cannot look at that, that makes me feel terrible. Well, we want to preempt that that's going to happen, have dosed you with some anti-nausea medication here so that by lunchtime we're not feeling too sick, we're interested in the lunch trolley, the flow-on effect to then eating, the nutrients, all of that's really, really important in the recovery process. So nausea and vomiting are big ones. You will get them, but we're aiming to try and keep them at a minimum and keep people well hydrated through that, and an oral intake of some sort in for recovery. Reduced blood counts, as I talked about, so the big ones, the red blood cells, the white blood cells, the neutrophils and the platelets, they're the ones we're sort of looking at every day. We're going to watch them go from this level down to this level and back to this level. Okay, we would expect that to happen. We know it's going to happen. We want it to happen. It needs to happen. We just need to manage the patient through the risks that happen during that low phase. Okay, and that's why most of the time people will be in hospital monitored quite closely during that time until the blood counts start to come up to a safer level. So infection, obviously when we don't have, most of you will know, when we don't have any white blood cells or any neutrophils, we're at a higher risk, so our immune system is very compromised and we're at a higher risk of infection, okay? Now infection can be anywhere. It can be respiratory viruses, it can be flus, it can be an infection of your Hickman line, it can be urinary tract infections, a wound if you've got one, ingrown toenail, a tooth, who knows? That's some of the things that we're perusing in the workup. Is there anything here on this patient's body that's potentially going to cause us issues when their immune system is low? And if it is, we're going to deal with that before you get started, okay? So infection, if you don't already know, is a really, really important side effect to be very aware of during your chemotherapy, during your transplant, and after your discharge from hospital. Okay, so the sign of an infection, the major sign of an infection obviously is a temperature, and any temperature over 40 degrees, I will not be the first nurse to tell you that you must act upon immediately. There's no mucking around, and if you take one thing away from this talk, it will be that if you have any sort of treatment anywhere in the space of chemotherapy, autologous transplants, allogeneic transplants, anything, and you're discharged and you have a temperature, you do not wait for your doctor's appointment the next morning. You do not ring someone and see what you should do. You get to hospital immediately. Certainly if your immune system is compromised, which most people undergoing any sort of this treatment is, it's extremely life-threatening if left untreated. Okay, we can treat it very well, but we need to have you with us very quickly. Okay, so no mucking around. We will treat infections with antibiotics, and we will remove the you're right. Remove the source of the infection if we can. If a Hickman line is infected, we will pull it out, and we'll put a new one in if we need to. Otherwise, we'll treat with a multitude of antibiotics to kill the infection very quickly, and monitor you closely with observations until your own white cell and neutrophil counts come up to help do the job for you. Okay, so that's one of our major risks post-transplant. And a common side effect is mucositis, so that is breaking down of the mucosal membrane of your mouth. So the mucosal membrane goes all the way from our mouth right through to our bottom, and it becomes very excoriated due to the chemotherapy, okay? So remember, chemotherapy kills our good cells as well as our bad cells, which is the stuff which is why things start to break down, why we lose our hair, why our mouth can become very ulcerated, okay? So there's many levels of mucositis, and one, I guess down the low end is not wanting to sort of swallow dry toast because your throat's quite sore, right through to the other extreme, which for some people is unable to eat, unable to talk, and even in some cases, difficulty with their airway. But that is very infrequent, and certainly in autologous bone marrow transplants it's less frequent than allogeneic transplants. However, no one is exempt from any of that, and it's just really important to remember that when nurses come at you with small little things like mouth washes, keeping up your mouth cares, letting them know if your mouth's bleeding, if it's sore, if you can't eat, therefore you're not getting your nutrients, all of those things are really important to be sharing, because they're really important in your recovery, and lots of times we can help stop them progressing, but we need to know about them. Okay, so a sore mouth is very likely. The level of that is just dependent on the patient and the type of chemotherapy you've had. So bowel changes, okay, certainly some of the chemotherapies are very renowned for causing diarrhea, Sometimes you might have heard of something called melphalan gut. So a high dose melphalan. Melphalan is very renowned for causing bowel changes, predominantly diarrhea, and it's quite common. We would expect to see it. It's a process that needs to go through. A lot of people say, I had my melphalan yesterday, I feel really miserable today, and that's very expected. Again, we're just monitoring that everything stays within the normal parameters for you, and that you know, you're coping as well as you can with it. Poor appetite and taste disturbances, hair loss, fatigue, stress and low mood. So they won't be new to you. They will be familiar to you, to anyone that's read or heard anything about chemotherapy or transplants. But again, just being open to the fact that they're predicted to some extent, and you know, it's not abnormal to have any of those. If your appetite is so off that you are unable to consume what is required for your nutritional intake, and you'll be frequently visited by dietitians, then there are ways that we can supplement you. Again, in an autologous transplant, it's not routinely done, but if someone did need to have some assistance with their nutritional intake, we can also give that through IV routes. So then we're in the waiting phase. Okay, we're going through the side effects. The counts have really dropped down to that low period, that low phase, and we can watch them go down in a book if we like. We at our hospital encourage patients to write them down and watch them come down that slope to hit the bottom, and then watch them start to come back up. That's good for your mental health too, to watch them start to come back up. It's you know, puts a positive spin on things. We use the term engraftment, okay, and it usually refers to a sustained neutrophil count of above 0.5. So basically that means that we're starting to see the neutrophil count come back up from a very low level to an accumulating level a higher level each day, and that will be the stem cells that we've put in from the freezer, making their home there and doing their job, okay. So it means the stem cells, that's right, have found their way into the bone marrow and are regenerating the bone marrow. And you can watch this all occur, as I said, with your following of the numbers. Really helps a lot of people to make sense visually of what they're going through when you can watch the numbers go down and then back up. Okay? So the discharge is also very dependent on that engraftment. It's different for everybody, but this essentially for most people will occur within 10 to 14 days of the stem cell infusion going in. Okay, so that's another really big thing I say to people. You do not have this bag of your cells back and wake up tomorrow morning and you're all fixed. Okay, very, very different to that. There is that low period of time where they are going to take about 10 days minimum to even find their way from that device in your neck down into your bone marrow. Okay, so the discharge certainly can't happen until after that. Now we have started some new processes where we're discharging people from the Royal Brisbane Hospital to outlying hospitals, so Sunshine Coast University Hospital in particular. They're in the processes of beginning to care for people post-autologous bone marrow transplants, hopefully with the view one day to do them up there. So sometimes we'll get people through that conditioning regime and actually give the stem cells and then move them on at that day or two after to be cared for in a hospital closer to home for this process to occur up until discharge, okay? So some hospitals in Australia do discharge people very quickly after they've had their chemotherapy to hotels and different sorts of things, and then it's routinely daily reviews. At the Royal Brisbane we keep you in hospital and until you're at a safe level to go home, which is usually around about that three week mark. 3 to 4 weeks, 2 to 3, very rarely 2 weeks depending on the type of conditioning you've had, but usually closer to the 3 week mark, and then you'll be sent home or back to your village, and usually your Hickman line will stay intact if it hasn't been infected, and you'll then come for daily or second daily appointments with your doctor in the outpatient unit, looking at your blood counts, having some blood or platelets if it's needed, checking for infections, checking your eating and drinking's going okay, and making sure that you're coping outside, and gradually that will drop off back to sort of every 3 or 4 days, once a week, once a fortnight, etc., until they're happy that you're at a safe level to go home into care. Now that's also based on patient compliance. I like to touch on that occasionally, because if someone has appointments, if they're sent home from hospital and they then have appointments in the outpatient setting, and they've got 3 in a week and they turn up to one of them, you know, you're ending up back in hospital because something's gone wrong very quickly, or the idea of getting home is becoming further and further away, while people aren't sort of complying with what would be needed simply to be safe. Okay, so that's really what we also need to be able to see from patients, is that they're going to act on things such as a temperature if they're in that situation, and also that the medications that people are discharged on are taken seriously and taken, because the effects, if they're not, are very unsafe. So really important also to do what they ask. When discharged, you want to rest and recover. You're going to be strengthening. The number one complaint post a bone marrow transplant from people is fatigue. Okay, so it takes a long time to recover. It's different for everybody. People say to me every day, when can I go back to work? When can I do this? When can I drive a car again? When can I ride my motorbike, ski, go on holiday? Whatever it may be, it's so dependent on the individual, the doctor, how they're travelling, how their recovery is going, but fatigue is the number one thing. So people 3 or 4 months post a transplant at home, they go out and they go over to the neighbour's house for lunch, or they go for a big walk or whatever, and they spend the next day flat on the couch because they've overdone it. Okay, so you just really need to listen to your body, and gradually, very, very gradually ease back into what you would call normal life. On to some of the practical things that happen in a transplant. That's kind of the clinical process of why we would do it, and what the aim and the outcomes are for a transplant. I'll give you some practical things based around our ward at the Royal Brisbane Hospital. They probably aren't too different to other hospitals, but they might have some of their own. Nicole might have some more intricate details on those. But what do we wear? Let's just, so the 5C rules. The rules at the Royal Brisbane Hospital are, so most people will, usually you will have your own room, and it's not always the case depending on the number of transplants that we have. But usually people will have their own room. There's occasions sometimes at the back end of a transplant when you're nearly time to go home that you might go into a shared space to share with people, because someone else is at the beginning and needing to move in. Someone needs the single room more than you do, but predominantly people will have their own room. You can have 2 visitors at your bedside at any time. And if you have 4 people coming to visit, that's fine. We've got a lovely patient lounge, and they can substitute in and out of the patient lounge, or alternatively you can come out to the patient lounge and sit and have a cup of tea and dinner or lunch or whatever with 4 or 5 people if you had 4 or 5 people visiting at once. But 2 at the bedside at any time, and that's a safety thing. If we need to get in there in a hurry, we certainly don't need to be clearing out 6 people, handbags, chairs, a whole lot of different things. So only 2 at once. No children are allowed on the ward under the age of 8. Now, depending on personal circumstances, David up the back will assess the rationale behind needing to have children on the ward under the age of 8. They are big bug breeders, and we have a number of patients with no immunity and very compromised immune systems. So little children tend to harbour a lot of bugs, and certainly in in the setting of patients having young children that are under the age of 8, certainly there's some ways around that rule, but we certainly just don't have lots of grandchildren and tiny tots and toddlers and whatnot running around the beds unless it's been approved by David and we get a lot of hand gel on their hands and things. No flowers on the ward, so the water that flowers are in breeds lots of bugs again, so chocolate flowers it is. You can come in and out of the room as much as you like as long as you're not on contact precautions. People sometimes think they need to be locked in. No, you can get exercise around the ward, go to the patient lounge, as I said, there's an outside area, etc. What do you wear? Whatever you like, really. Comfortable clothing. I do educate all my patients that I would encourage people to get up out of their pyjamas, open the curtains, get the bed made, have a shower, get into some sort of tracksuit or some sort of, you know, when you're in the bed still at 3 o'clock in the afternoon and the curtains are closed and you've still got your clothes on from overnight, the world's not looking too bright. So I really encourage people to get up and put some day clothes on so that you sort of go back into those at night. But if you want to wear a gown around for the whole time, that's your choice. Comfortable clothing and warm clothing, it's quite cool on the wards, and enough of it, because if anything spills on your clothes, there's any bodily discharges, any accidents, anything like that, it's just really best to just dump and get rid of it. So nothing too expensive or fancy, just things that you're probably happy to chuck out if it was necessary. Okay. Why do you have to wear shoes? So hygiene one, because you're at a less risk of you're at a reduced risk of falling if you have footwear on. Okay, there might be things on the ground, slippery things. The floors actually in our ward are quite speckled. Quite often there might be a pen lid, there's something off the top of a medication tube or something that you could slip on. And remembering that most of you travelling around the wards at that time don't have very little platelets, so you're at an increased risk for a number of reasons of bleeding. So falls can be extremely, damaging. So we really just want to reduce that risk. Okay, so footwear, so rubber thongs and whatnot aren't a great idea. Something that's quite stable on your feet to be moving around, a good solid sort of pair of slippers with a sole, not those sort of fold up floppy things that probably cause you to trip over more than not having them on at all. Can you bring your own pillow and blanket? David, do you want to answer that? Yes, you can bring your own pillow and blanket, but again, you certainly don't need to. If that's a home comfort to have a throw or something on your bed, that's yours, a bit of colour. Look, I'd probably do that if it was me, but you also want to just keep in mind that, again, if there's any major messes, anything like that, it could end up going, okay? And we still need to be very focused on the importance of hygiene around that, so we would still be asking for it to be changed and kept fresh, okay? Oh, where do you park? I tend to direct this question elsewhere. But look, there's the buses that come to and from the Leukaemia villages. There's some parking at the hospital. There's some parking passes that our social workers can work with you to get for families. So part of the pre-transplant workup is to spend some time with the social worker, and you've usually also heard from the girls. So it's just a case-by-case basis on who needs what at what time. I know a lot of the complaints come that the buses are fantastic, but if you're having treatment at 8 o'clock in the morning or at 5:30 in the afternoon, the buses don't necessarily lend themselves to that. But then in the next breath, we're telling you not to get on public transport because we don't want you exposed to all of that. So case-by-case basis, and just doing what we can to minimise the costs, but also minimise the use of being on the Brisbane City Council buses with, the rest of the world. Okay, so ask about that. We will point you in the right direction for people that can help you with car parking. what can you do? Oh, what can you eat? What can you do? Okay, what can you eat? All meals are provided to everybody. Some people decide to eat very little of that and cater for themselves. That's fine if you want to do that. In the patient lounge, there are 2 big fridges at the Royal Brisbane, and they can store food of your own, okay, and there's a kitchen. If you're a person that wants raisin toast and a banana at 6 o'clock every morning, well, you can go out there and make it for yourself, and a cup of tea, sit down, watch the news, read the paper, whatever. But you certainly don't need to bring any food if you don't want to. It's totally up to you, but it's also about what you can eat and what you feel like, and a lot of people pull the lid off and think they're not having that. A lot of other people think that it's lovely. So keeping up your food's really important though. What can you do? You'll be kept very busy by people prodding and poking you a lot. Most people say they can't wait to have a good sleep when they get out of there. You will be woken every 4 hours, and that is absolutely for your own benefit. To leave people any longer than that, you know, we're increasing the risk of not picking up on things early that could be, you know, going a little bit off track. But you can read, you can walk, you can play iPhones, iPods, laptops. I mean, the list is limitless. What else? Don't bring too many valuables to anywhere. That's all pretty normal. You don't really need any money. So, anybody got any questions? David asked, has read in some of the literature that sometimes they suggest chewing ice, sucking on lollies, different sorts of things during the process of the infusion of your stem cells back. So sometimes the sucking of the ice can happen after, also for the sore mouth and things like that. So as a treatment path of ulcers and inflammation in your mouth. But for the infusion, you can get a very metallic or a yucky taste in your mouth when the stem cells are going back in, okay? And the preservative agent can cause that taste in your mouth. So we usually say to people, bring something nice to suck on, bring something that you want to eat, or you can chew ice, any of those sorts of things, to take away from that process, basically. Now, when you have the DMSO so the preservative agent that's mixed into the stem cells goes back into your body, and it is secreted through your sweat glands and through your skin. And so when you have had the infusion, after that your breath, okay, and the room, everything about you at that point in time can smell, okay, of this preservative agent. Now, when it's happening, you can't smell it, but the people around you can, okay? So you'll probably be thinking, what's everyone talking about? But we as staff, as family, etc., coming in, can smell in the breath that there's a strange scent. Now everyone says it smells differently. Some people say molasses. Some people say, you know, sugar cane, these sorts of things. I think it smells like cool fruits. But I don't know if anyone knows what do you guys reckon it smells like? What do you say, David? It's not an unpleasant smell. It's cool. Yeah, it's quite a sweet smell, but and it just, yeah, depends how much you've had, and it sort of will waft the corridors for a bit, and it goes away. But usually you can't smell it. But if the person next door's had a transplant, you will, so you'll get to see what it's like. Can you burn essential oils was the question. Sorry, just for those who didn't hear. Yeah. As long as, yeah, it's not sort of overpowering to anyone else. But yeah, no, definitely no candles. A lot of people think nice candles would be nice, which they would, but the flame and the smoke obviously is the concern there. But in your room you can have, you know, photos and all things to make it like home, decorate, etc. If you want to have things next to your bed that you would have at home, those sorts of things, you know, they're all important in the recovery process. But yes, predominantly many people go back to their working life, and they're normal, new normal because of appointments, and you're never going to have not had a transplant or not had cancer, but the new version of normal evolves, and that's exactly the purpose of doing these transplants, is to give people a quality of life moving forward after the treatment and diagnosis of such diseases. Do you need to be totally in remission to have a transplant? Again, there are special disease requirements to meet, which is why people undergo a bone marrow aspirate before a transplant. There are special thresholds that need to be met or kept under or below, thresholds that need to be sort of met in order to be accepted and a suitable candidate for a bone marrow transplant. So for some people that may at certain levels require more treatment and more chemotherapy for both the type of transplants to get them to a certain level to be able to have the stem cell collection, because we need to ensure that we're not mobilising a whole lot of cells that are riddled with disease. And secondly, then to come into the transplant, we want to see the levels at a certain level. But again, that's very case-by-case basis, and takes into account people's age, takes into account people's treatment, relapses in the past, etc., etc. So again, very clinically specific to the patient. But that sort of thing is the absolute purpose behind going through the pre-transplant screening, because ultimately, we don't want to mobilise a whole lot of cells, as I said to you, that aren't going to be beneficial in the transplant, and B, that people are in a clinically appropriate condition to undergo the actual processes of the transplant, okay, based on huge amounts of statistics and data for how we would predict people to handle the transplant based on how people have done in the past, basically. So how long after a transplant until you go into remission? So the idea would be that we're getting you there with that big dose of chemotherapy. So the idea is that we actually don't want to see the disease again post the chemotherapy. Now, remembering that different diseases have different curative rates. Some diseases cannot be cured, and at that point it is about us extending the period of time that people don't need to have treatment for, okay? So lymphomas and myelomas differ a little bit there, okay? And we're aiming for quality and length of time without relapse disease post the transplant, okay? But again, to suggest the outcomes of what's going to happen after transplant is, really very complex to everybody's individual case and disease to this point. Because we are transplanting while people are having this transplant, where people are coming from to have this transplant that looks quite similar to everybody is so varied. It's so varied, and if an individual has an individual comorbidity, which means a sort of potential problem coming into transplant setting them. If they've got a heart that's a little bit dodgy, for example, before they come in, and we might reduce things for their transplant that the person next door is not having, which will then potentially change the outcome. So the reason to do them is that the outcome is more beneficial than not, obviously, and that we are really wanting to give the quality and life without the disease for as long as possible as we can. But to comment that when or if it would ever come back is very difficult. Sorry, I can't give you an answer to that. Absolutely. Absolutely. Research into bone marrow transplantation into hematological malignancies is absolutely an emerging, hour by hour emerging space. and it's really, really phenomenal the number of clinical trials that we're seeing and the number of advancements that we're seeing daily. It's definitely probably something that we see more of working in the profession and on the professional side of it compared to a...
The advancements they're doing, is it a short time?
Oh, there's so many different ones. So we're running a number, for example, we're running a huge number of clinical trials at the Royal Brisbane Hospital at the moment for very specific different diseases, for very specific different patient cohorts, to really, really track everybody. There's nobody that would go through our space really that we're not collecting the appropriate data on, and that's what Caroline does, to really, really look at how we're going to, better treat patients such as yourselves in the future, the advancements of treatment, the advancements of transplantation, who we transplant, when we transplant them, why we transplant them, is a constant daily profession for a lot of very...
A lot of work.
Yeah, absolutely, but a lot of people's bread and butter day in, day out, that they have actually studied medicine and moved in a nursing profession to just devote their careers to the research behind everything that we've just talked about here. And absolutely, I'm very sure that in 5 years' time, if we stood here and did this talk, and then another 5 years' time after that, some of the stuff I've just told you will be replaced with the new evidence. But trust in that the treatment given to you during your transplant will be the most up-to-date, evidence-based treatment that that we as health professionals can give you on that particular day at that particular time. 10 years ago you wouldn't have had it. 10 years' time, who knows what we'll be saying. How long can stem cells be frozen, and do they ever lose their viability in the freezer? Absolutely, they always lose their viability, which is why what we're collecting at the start is taken into account that we're going to lose some. Okay, so for a myeloma, for example, we want to get 5 million stem cells in the bag. Okay, so we only may need, well, I'm just making it up, we only may need at that particular time 2.5 million, 3 million, etc. We maybe want to be able to use some in the future, or we're accounting for the fact that we know we're going to lose some. Okay, just in the freezing process and then the defrosting process, some of the cells will be lost, but a huge amount of what's called viability studies are done at different times throughout, and you can actually do viability studies on stem cells while they're frozen. So that's part of the process of our specially trained transplant scientists, is to be monitoring those cells, and then quite often I'll get a request from a doctor to say, John Smith's had his cells collected 3 years ago, we're going to move to a transplant, can we check on the cells? And so at that point the scientists will do some procedures on the frozen stem cells to see that we had 4.5 million at the time, and now we've got 4.1 million now. So a good question. So what's what sort of preparation for the home, to return to home, and around pets? So depending on whether I would assume you're going to return to your sort of family, your home, not to a village such as this. So you're going to be in hospital for a length of time. There's no need at that point in time that the house, during that whole hospital time, that she's running herself ragged trying to keep everything, up to date. Quite often, what I haven't talked about too much, but I can talk about it individually if anyone wants to know any more, is the role of the carer. But essentially the role of the carer is post-transplant, and really, really, really important that you, as the carer, we say the carer needs a carer, really important that the carer looks after themselves during the time the patient is in hospital, because getting themselves to the hospital bed at 6 a.m. to be by their partner, to be then going home at 6 p.m. and absolutely, just crashing on the couch for 3 or 4 weeks straight while they're in hospital, by the time it actually comes home, and that's their job now, is to be the carer and to be the nurse, essentially, they're already too exhausted. So if she's running herself around trying to keep the house up to speed while you're not even there, it's not necessary. What is necessary is when the warning signs are coming that you're looking like moving towards going home, that yes, things are hygienically clean.